in response to your question, I think yes, we can end the epidemic as long as cost is not a barrier to access to PrEP. I think we have seen successes already in PMTCT, where we probably have a new AIDS-free generation. And so if we can continue to maintain that and also make HIV make HIV testing a routine, everybody maybe when you go for your annual medical checkup, have an HIV test without being prompted. So we can maintain those who are negative to stay negative, and then see how we can work on that. So my really important point is all about access to the new technologies without any cost issues around. I know there's issues about global economic downturn, but I think that shouldn't be a barrier to access to any new prevention technologies.
I mean, I think that one of the things we should do is look at another global health area and say, what are they doing that we're not? And I'm looking at vaccines. So we've got the global eradication target for elimination of polio. So we're trying to get rid of polio in the world. Now, what's the difference there? What happened there was that there was a global decision to do it. It was a global decision. It was backed by the UN agencies, massive input of money and backing from Gates and from other donors. That it was something that all countries just universally adopted. As Tony's concerned that people are not going to adopt it, but all countries said, yes, we're going to do this. And in fact, it's a bit of a name and shame game. If you're not doing it around polio, you're named and shamed. And it's been made very fashionable at the moment because of the decade of vaccines. So we need to look at some of these other successful interventions and take them into our field and say, is this something that we can now, because we've got the tools, which we didn't have before, is this a point? At what point in history can we say that we should actually do the equivalent and say, right, world, we're going to set a target, we're going to do this, and every country is going to set its own targets towards that, because that's what the vaccine world has done.
No, I very much agree with what Helen said. As one aspect, we have to learn from other experiences. What have they been doing? And I was even, as I was thinking before coming here, I was even thinking about the smallpox thing. What's similar? What is different? Obviously, the intervention was very different. It was a vaccine that was given to everybody worldwide, etc., etc. We have a different toolbox here. And I think we're still struggling, and I think we have to be analytical to say, well, yes, we want to get there, but let's be analytical. What would it take to get there? And I think, obviously, we always fall into the resource conversation. Clearly, yes, resources will be needed, but also we have to be honest. We still have some answers that we need to find on how does the arsenal of tools best fit together. And how will we inform? How will we prioritize? And yes, you can say WHO do the guidelines, but the difficult question is how will we put the tools together in a rational way to maximize the resources that we have to get us as close to ending the epidemic as we think. And the other reality check that we need to have is how will we strengthen the systems to deliver? And yes, it will need resources, etc., etc., but you won't strengthen the systems overnight to get there. So we will have to really see what are ways of getting systems to deliver. And the last point, I think we'll also have to say, how can we create the demand for the services that we think everybody wants? Because maybe not everybody is rushing to get it, as we see from testing. We have very few people still in many places that know their status. So how can we be better, and how can we understand better to create the demand, getting people being willing and to adhere to lifelong interventions that might be primarily for prevention purposes. Yeah. So I think we should be analytic and say, let's see, what are the 3, 4, 5 things that we need to do? What is the research that we still need in terms of implementation research that we haven't done yet?
Yeah, just to add something to that, Helen, I know you would agree with this, is that the situation with polio and smallpox has some similarities, but in many respects it's completely different. We had a highly, highly effective vaccine for both of those. So it was a question of a one-off, one shot, go in and do it. And even then, it was difficult to do over many, many years. So we're dealing with so many complex sociological and other issues, stigma inherently related to a fundamental part of our existence, which is sexuality. I mean, we all know that, how complicated that is. So it's not going to be we're going to decide to have the will to go ahead and do it. It's just so complicated.
Bob and then Mike.
I think that there is not a single answer, not a single solution, and it starts with understanding and mobilizing the different communities, each of whom benefit from different parts of the discoveries that have been described recently. Oral PrEP is the only intervention known to work for MSM, who have a 19-fold increased risk of HIV infection around the world, including in Africa. And, but there's other options for other groups. And I think that understanding and mobilizing the communities who are suffering from this epidemic is really job one in terms of the scientific agenda, and that in turn informs policy and prioritization.
What? Mike, Bob, you don't think the treatment for prevention is equally applicable to MSM?
I think it probably is. And it has been in San Francisco, where early treatment's been policy, and we've seen a decrease in new infections. I was referring to randomized clinical trials that have demonstrated efficacy for PrEP.
Just really quickly, just getting to Phil's question, I mean, I think that we have to be honest in a sense and have humility. We're facing a challenge if we're going to use antivirals or an antibiotic agent to try and eliminate or even reduce drastically a disease. We don't have a lot of experience with that. The Chinese, talking about mobilizing, the Chinese dealt with this huge syphilis epidemic in the 50s because they had single-dose benzathine penicillin. And they were able to mobilize the entire country and deal very effectively with this epidemic, but they had a huge advantage in terms of what at that time was their political culture, and which I don't think, it's probably not applicable to the United States, and they had single-dose benzathine penicillin. So as we try and do this, which I certainly embrace, you know, this is an experiment as we try and move forward. So I don't think it would be fair to say, oh yeah, this is going to work just great because somebody can model how work it. Well, it's an experiment, and we have to be honest.
Let me ask the questions still standing to maybe give them in quick succession.
Thank you very much. My name is Jim Pickett. I work with AIDS Foundation of Chicago. I head up the International Rectal Microbicide Advocates, and I'm a person living with HIV for the last 16 years. And thankfully, people with HIV, our voices, our experience, and our wisdom has been really important in driving policy and programs and improving our response over time. And what's been really missing, and Bob talked about mobilizing communities, what's been missing from 99.99% of conversations around PrEP, including in this room, this panel's already big, we probably didn't need more on this panel, right? But we have not heard from one PrEP user. Most of the discussions treat PrEP users as some kind of theoretical them. They, who are they? Well, they have names. There are people who are taking PrEP right now. There are thousands of people who have been in PrEP trials that we now know are effective. The trials worked. They're PrEP users, and we should really be listening to them. So I encourage everyone on the panel and everyone in this room, next time you have a conference or a meeting, bring a PrEP user, actual PrEP user, to talk about their experience instead of thinking about it for them or thinking about the theoretical they. And as you're thinking about creating countrywide guidelines and prioritizations, while you're making WHO guidelines, while you're determining how you're going to spend precious resources, how we're going to roll out programs in any kind of jurisdiction, as we have had to listen to and need to listen to further people's voices living with HIV, let's mobilize the communities who want PrEP, who are HIV negative, who want options, and let's hear from them before we decide for them what we are going to do or not going to do. Thanks.
Thanks, Jim. Tim.
Had I known that Jim was going to be so eloquent, I wouldn't have stood up behind him. But just a point about the previous discussion and the challenge, and it's great to see everybody dreaming about how we're going to end the epidemic and this, that, the other, and it's great to have the vision. But please, let's not leave all of us this conference thinking that we have the solutions. You know, we have some clues as to what we might do. You know, we know how to do it, but we just don't know how to implement it. It's going to take time for that to happen. You know, I enjoy this discussion, but please, it is a theoretical discussion. And I'd hate every people going back from this conference thinking at the Rome conference they sorted it all out and now we just got to go and implement, because it's actually going to take years for us to learn how to translate these results, which are in very, very special populations. They are in randomized clinical trials in some very, very special populations with an incredible entourage for the whole milieu. And to translate those to a more general population, or even the general population of stable discordant couples, is very, very difficult. So please, give time for this information to digest. Give time for the implementation research to happen. I'm not saying don't do it quickly, but please, let's keep the conversation about when and how we're going to eliminate the epidemic to maybe a couple of conferences down the line. Thank you.
Great, thanks, Tim. And I'm going to let the panel respond after this last comment.
Hi, yeah. I'm Nathan Ford. I work for Médecins Sans Frontières, and we're an implementing agency, so we support programs, but we also do operational research. And to follow on from the last question, in order to be able to, that distinction was well made by several panelists about the difference between guidelines and the implementation of the guidelines, the local adaptation. And for us to be able to support with the operational research, we do need to work within a framework of guidelines. And a question that's been coming to my mind in the discussion is that at the very beginning the question was asked about the guidelines for discordant couples and that it would take a year. We've since heard from Helen that that's a ready to try out strategy, and we've heard from Renee that there's a quadruple whammy. So I just wanted to go back to that difficult question and put Gottfried on the spot and ask why it's going to take a year for those guidelines to come out. Thanks.
No, thanks for this question. And actually, I didn't refer to the couples testing and counseling guidelines. I referred to sort of the broader panel looking at the whole range of guidelines that currently out there. The treatment guidelines, there was a reference to the PMTCT guidelines. We clearly need to look at the PMTCT guidelines again to say what is the next generation of PMTCT guidelines, HIV/TB guidelines, and obviously from the new evidence about that we have been learning here about what does it mean for prevention in different situations. So I'm really thinking about sort of the broader set of guidelines and how can we be best informed within the next 6 to 12 months based on this high-level panel that we are putting together to say what is a meaningful next generation of guidelines and what are the logical increments to go there. For the couples testing and counseling guidelines, we're really hoping to do some more operational work, fine-tune some of the definitions that are in there that still need to be looked at, to maybe some more modeling to see what it actually will result in, see to what extent knowledge from the PrEP studies would have an influence there, but we hope to have this within a few months. So really it's not going to be, I didn't refer to that when I said a year.
Great. Thanks, everybody. Let me start, I think, Dan, if I may, with Steph on the end. If we can do quick comments back to many of those last comments that were, I think, good and fruitful comments, but just to have you each, going down the line, reflect and perhaps provide a bit of a closing thought. And I'll start with you, Steph.